I welcome you all in this day 4, second scientific session of 18th annual meeting of the Pakistan Endocrine Society. I'm Dr. Nanik. I'm assistant professor and consultant endocrinologist at Aga Khan University Hospital. With me today is Dr. Sara Nadeem. She's also assistant professor and endocrinologist at Aga Khan University Hospital, Karachi. And today's session theme is breaking down the pituitary dilemmas for better clinical decision making. We have an excellent speakers and panel of experts today. Let me introduce first the panel of experts. We have Professor Najmul Islam, a renowned professor of endocrinology in Pakistan. He's a professor of medicine and endocrine at the Aga Khan University Hospital. He also section head at the Aga Khan University Hospital. He's a past president of Pakistan Endocrine Society, and he is very famous professor in Pakistan. We have a second panel of expert, Professor Tasnim Ahsan. Professor Tasnim Ahsan is the Emerita Professor at Jinnah Sindh Medical University, Karachi, and she's also Dean of Medical Institute of Diabetes, Endocrinology, Metabolism, Karachi. Today, in our session, the first speaker is Dr. Laura Dichtel. Dr. Laura Dichtel is an assistant professor of medicine at Harvard Medical School. She's currently working at Neuroendocrine Unit, Massachusetts General Hospital, Boston. Let me further introduce her. Dr. Dichtel completed her clinical and research endocrine fellowship at Massachusetts General Hospital. She joined Neuroendocrine Unit and Pituitary Tumor Clinical Center at MGH, where she managed pituitary patients with pituitary tumors and other pituitary disorders. Her research interest is to investigate endocrine dysregulation in obesity with the role of growth hormone and insulin-like growth factor axis in etiology and progression of NAFLD. She's a PI of many funded research projects, and she received research-based awards, including Young Investigator Award and Clinical Innovation Award. So, without any delay, I'm handing over this session to Dr. Laura Dichtel.
Great. I hope you guys can see my slides and that everything looks okay. Please just let me know if not. So I just wanted to say thank you and just what an honor it is to be here today. As requested, I'm going to speak about the approach to pituitary disease with a focus on pituitary adenomas. I have no conflicts of interest for this talk. As you mentioned, I am in the Neuroendocrine and Pituitary Tumor Multidisciplinary Clinical Center, where I am very fortunate to have many colleagues, and our specialists include the neuroendocrinologists like myself, neurosurgeons, radiation oncologists, radiologists who specialize in the pituitary, also neurology teams and psychiatrists. And so we really work together to put our heads together, especially on some of these complex patients. So we don't have much time, and so I'm going to kind of go pretty quickly, but I'm going to outline a little bit of pituitary pathology and what we see here at MGH. And then I have two cases. I'm trying to be in the spirit of breaking down pituitary dilemmas for better clinical decision making. And then we'll take questions at the end. I know I do not need to explain this to a nuanced endocrine audience, but the reason why I like neuroendocrine is because the pituitary truly is the master gland, and I do feel like I'm very subspecialized, but I still get to take care of all of the different hormone axes. And so that's why I really like it. Obviously, when I'm talking to other audiences, I try and simplify this and break it down and show them that it's not as bad as it initially looks on some of our very complex feedback diagrams. I do want to just point out that we look at all of our own MRIs. Obviously, we still rely on our radiology colleagues, but I encourage everyone with neuroendocrine and pituitary disorders to try and look at their own pituitary imaging when possible. So I'm just going to go over a normal pituitary scan here. at the risk of, I know many of you probably know how to look at a pituitary MRI, but it'll kind of anchor us for the rest of the talk. So this is a T1 post-contrast coronal image, and it's just a pretty normal pituitary. So you can see the optic chiasm here, and you can look here for the schematic, the nice, relatively straight stalk. Not everyone is perfectly symmetrical, so it's okay that it's slightly deviated. The head is also tilted a little bit in this image, and then the pituitary is hyper-enhancing with contrast. And this is the T1 post-sagittal, where you can nicely see the stalk coming down. You can see the nicely enhancing pituitary gland, and you can see the optic chiasm and nerves coming forward. So we do see a large spectrum of pituitary pathology. This ranges from anywhere from benign lesions, which obviously pituitary adenomas are the most common. And we also see craniopharyngiomas, both papillary and adenomatomatous, and also meningiomas in terms of the benign lesion category. We see a fair number of cystic lesions, so craniopharyngiomas can fall into that category. But we also see Rathke's cleft cysts, pars intermedia cysts that are seen incidentally, arachnoid cysts. We do see a fair number of malignant lesions that occur in the pituitary area. I won't go through them all. There are different etiologies, but I will point out that pituitary carcinoma, while rare, all of these cases are very memorable to the care provider, because they're very complex and difficult to take care of. And often you're dealing with metastases as well as hormone production with these patients. We also see CNS lymphoma and metastatic disease. So as you know, we worry about apoplexy, one of the endocrine emergencies, postpartum Sheehan syndrome. Abscess and infection are rare in the pituitary in the absence of instrumentation, but we still watch for that. We see a whole host of infiltrative and inflammatory diseases, and we work with our neurology colleagues to help diagnose these. And we also follow different patient populations. So those that we have a large cancer center here, and many patients have central nervous system radiation, and we monitor pituitary function after radiation to the pituitary, as well as a traumatic brain injury population, either from sports and or military service. We have different programs to help those patients get to our clinic in a comprehensive evaluation. We can see hemochromatosis, and then pituitary hypertrophy. We never want to forget that physiologically we can see that in pregnancy or hypothyroidism. So I just want to start by showing this MGH case series of Sellar lesion diagnoses. And I think what's just so impressive about this series to me is that it's a series all here at Mass General of 1,469 transfemoidal surgeries over a span of about 10 years, 1998 to 2009, for Sellar masses. But it was by a single neurosurgeon, Dr. Brooke Swearingen, who is still our senior neurosurgeon here. 92% of these were adenomas, 8% were not adenomas. And that included 116 lesions. So by far, we really are seeing adenomas. The most common non-adenoma lesion was a Rathke's cleft cyst at 42%, making up a bulk of these cysts here. But we also see benign neoplasms, malignancies, and inflammatory diseases. And it's important just to point out that these cases were both cases that went for resection and for Sellar biopsy. So not all pathology was as expected, and I think that that's a nice point that this paper makes, this publication, is that 2 meningiomas and 4 metastatic lesions appeared as possible adenomas on imaging. And radiographically, a classic Rathke's cleft cyst was actually a craniopharyngioma on pathology, and one vice versa. A classically radiographic looking craniopharyngioma turned out to be a Rathke's cleft cyst. So often we're humbled by what we eventually see, but we like to try and understand what we're seeing from the radiologic diagnosis. And so when we are looking at our pituitary microadenomas, we often don't see them on the pre-contrast lesion. This one you actually can start to appreciate because the Sellar floor is a little bit deviated. But on the post-contrast images, you start to see the hypodensities, and you can see that this is a nice hypodensity here on the sagittal. Our pituitary macroadenomas, when I'm looking at the imaging there, often, obviously, the contrast helps us bring out definition. What we're obviously looking for is mass effect. Are we seeing effect on the optic chiasm? Are we seeing invasion into the cavernous sinus? And often the post-contrast coronal and sagittal images help us understand that. And just to show a Rathke's cleft cyst, there is no sort of 100% classic Rathke's cleft cyst, because on the T1 pre-imaging, it can be bright. If there's a lot of protein, it can be hypointense. This is the T2 coronal. It can be bright. It can be hypointense. I guess what would be most classic is that the post-contrast imaging has a hypo-enhancing lesion, and often you can see the normal pituitary tissue draped over that is enhancing with contrast. So in summary, adenomas are the most common sellar lesion, but the differential is wide. And as you know, the prevalence has been quoted as greater than 10% on autopsy slides for pituitary adenomas. And what, their numbers vary, but lactotroph adenomas with hyperprolactinemia, which luckily can be medically treated in most cases, are the most common, followed by the gonadotroph or non-functioning adenomas, which we watch for visual field loss and hypopituitarism. There are obviously the cases of acromegaly and Cushing's, which may come to attention because of actually the hormone secretion themselves rather than the lesion, and a very small percentage of thyrotrope adenomas. So, I actually really love taking care of these patients because they show up at our clinic in all stages of workup, some with a lot of workup and some with very little. So sometimes this is just an incidental finding on an MRI and then the patient comes to us. Sometimes there's been symptoms, sometimes long-term symptoms, as you know, with Cushing's and acromegaly, and that have hormone abnormalities that are found on evaluation. And sometimes they come a little bit more urgently, or sometimes through the neurosurgery service when they have mass effect symptoms and there's a concern because of the lesion size itself. So just one more slide of background before jumping into a case, but I do try and approach every pituitary adenoma or even every sellar lesion in somewhat methodical way, just so I don't miss anything. And so number one, I really try and address any diagnostic uncertainty. So we can't always predict from the MRI, what this might be, but with a combination of the initial MRI and the labs, we can sort of start to try and figure out what is this lesion and where do we go from here, and if we need further workup, like a lumbar puncture or biopsy or consultation with neurosurgery, and we have some subspecialized neurology teams as well. Is there a concern for mass effect? We can obviously do confrontation testing in the office for visual fields, but do they need a consultation with neurosurgery if we're concerned that they might need to go to surgery soon? And it often dictates urgency of treatment. And we do really like to have the formal visual field assessment so we can determine what really are the visual deficits and how is that going to change with treatment. And then it gets to the meat of my job and probably your job, which is evaluation for hormone overproduction. And obviously, as discussed, the adenoma subtype can dictate the approach to treatment. And then evaluation for hormone deficiencies. And this is particularly a concern, as you know, with pituitary lesions greater than 1 centimeter, but also for stalk thickening, infiltrative lesions, or any empty sella. We continue to work up for hormone deficiencies as well. So I picked two cases. It's a short amount of time that we have together. And so I learned from both of these cases. And so I hope that it's helpful for your perspective. I have a 21-year-old woman who came to me with headaches, amenorrhea for 3 months and galactorrhea, and she presented to her OBGYN. So on her initial labs, her prolactin was 125 nanograms per ml, with normal being less than 23.3 for a woman. Estradiol was low normal, not quite in the postmenopausal range. Her LH and FSH were low normal as well, and she had a negative pregnancy test, and these other testosterone, DHEAS, 17-hydroxyprogesterone were all normal. So they ordered an MRI, and for whatever reason, because this isn't quite standard of care, there was some discussion and they decided to start an oral contraceptive pill. And so she was on that for about 6 to 8 weeks before she came to us. So on the initial MRI, we see a 9 by 12 by 13 millimeter non-enhancing cystic lesion, and it's central in the sella, and there's some suprasellar extension. So pre-contrast, we can see that it's a little bright here in the sella. Post-contrast, you can see that this is probably the normal pituitary tissue draped to the side, and on T2 weighted imaging, you can really see that it's even brighter than CSF, which you get a little peek of up here, but it's quite a bright lesion. And looking looking here sagittally at the post-contrast image, we are worried about optic chiasm compression as well. And interestingly, if you can have the scrolling capabilities, we actually didn't see any visual field defects on the evaluation, but there was slight pallor of the left optic nerve head, and you could actually see that impact if you scroll through these images. So the first question is, do we think that this is a cystic prolactinoma or a cystic adenoma? Her prolactin is 130 or 120, and she has this large cystic lesion. Well, we all know that the prolactin level generally reflects the size of the prolactinoma, with idiopathic hyperprolactinemia having very mild elevations, and a small adenoma can have anywhere from 50 to hundreds, depending on how strongly producing it is. Macroadenomas are distinguished from stalk effect by papers showing that a cutoff of 100 nanograms per ml reliably separates macroprolactinoma from stalk effect. And then, as you all know, I'm sure everyone has seen these very large lesions that come in with prolactins in the 1,000, 2,000s, 10,000s, very high levels. But what we do know is that cystic prolactinomas may have a lower prolactin level than expected for the total lesion size. And this is really because we just think of that solid component as producing prolactin and that cystic component as not being hormonally active. So, when I think of prolactin levels, I think of that 94 or 100 cutoff, where it distinguishes stalk effect from a true, macroprolactinoma, and that's a very helpful level. A level of 200, 250 has really been shown to separate some of this drug-induced hyperprolactinemia from macroadenomas as well. And a level of 500 has been published to show that that's pretty reliably, if you have a level of 500 above, going to be a macroadenoma. But I think where we get a little bit confusing is that, I think this patient, I was pretty confident that this was a cystic prolactinoma because it was well above 100. But we do know that the poorly functioning macros and the cystic adenomas can have lower than expected lesions. So where we get into trouble is that, let's say she had a prolactin of 80. Do you think this is a cystic prolactinoma, or do you think this is stalk effect? And then we might actually not know, and then we might just actually have to decide if we're how we're going to treat that without truly knowing. So we did additional laboratory workup when she came. So the prolactin was repeated as 150, which is even more confident that this is a true elevation and it's a cystic prolactinoma. She had an IGF-1 of 177, and we always get an IGF-1 in these patients with hyperprolactinemia just to rule out co-secretion because acromegaly changes management. Her paired TSH and free T4 were normal in our assays, so she had no central hypothyroidism, and she had a morning unstimulated cortisol of 18.5. Where a level of greater than 18 proves sufficiency. And we really must confirm the adrenal axis is intact at diagnosis for these macroadenomas, anything above 1 centimeter. So I know this isn't a truly interactive session right now, but is anything bothering you about our workup so far? Because when I had this patient and I had these labs, something started bothering me because she's now on an oral contraceptive pill. And what we know is that oral estrogen can do a couple things to our hormone measurements or to our hormones. Number one, it can actually lower IGF-1. So I think about this, to me, I'm not concerned about acromegaly because oral estrogen can't lower IGF-1 that much. But if she had an IGF-1 of 450 or something high normal, I might actually want to see what her IGF-1 is off of the oral contraceptive pill and consider an OGTT for growth hormone suppression. And then we know that oral estrogen can raise serum total cortisol levels by raising CBG. And her morning unstimulated cortisol, we're relying on that to say that she's adrenally sufficient. So this is a real pitfall in adrenal axis testing, is oral contraceptives, and a lot of our young women have hypopituitarism and do need hormone replacement. What we know is that 70% of total cortisol is bound to CBG. Patients on oral contraceptives have a variable and potentially robust elevation of CBG. Total cortisol overestimates the adrenal axis activity in this situation, and free cortisol levels are not affected. So the problem is free cortisol levels aren't necessarily widely available, and they're not widely available because they're not widely used because we don't really have cutoffs for them. So what we tried to do is look at a healthy population of about 250 subjects with normal binding globulins and say, what is the free cortisol that corresponds with our total cortisol of 18 that can predict adrenal sufficiency? And we found that a free cortisol level of 0.9 micrograms per deciliter predicted that level with good sensitivity and specificity. And other studies have demonstrated the same by different methodologies. So looking at true adrenally insufficient individuals, comparing quart stims to those without adrenal insufficiency, which I think is very reassuring when you have two studies by different methodologies that show a same cutoff. And this is just actually some of our own data. This is patients on oral contraceptives showing their CBG, and some have CBGs quite like the healthy controls, and some have very high CBGs. So your options for adrenal axis testing in this patient, you could perform a quart stim test with free cortisol levels now while she's on the oral contraceptive, if those are available. They're not available to some of even our colleagues around here in other hospital systems. Or we could discontinue oral contraceptives for 2 months and reliably test the total cortisol. The obvious problem here is that you have to wait for 2 months and you're not quite sure if this patient's adrenal axis is intact. Luckily, she doesn't have symptoms. You don't have a very high suspicion, but we want to be careful because of the severe nature of adrenal insufficiency. And I just think that it's helpful just to look at some numbers in this case, because I think it's humbling when you look at our cohort and some of them who did have quart stims to see how high these total cortisols get, yet the free cortisol levels are quite modest. And if you take that same patient off of oral contraceptives and re-stim them, you see how much lower their total cortisol levels are. So it just shows us that you really can't rely on those total cortisol levels in patients who are on birth control, especially oral contraceptives. So her adrenal axis was intact by free cortisol levels, and we had a discussion of her goals. She didn't want to become pregnant currently, which is lucky because we wouldn't want her to get pregnant right now anyway, but maybe she would in the future. And then we also reviewed the provider's goals. So my goals were return of menses, estrogen exposure, attempt to shrink or take away the lesion and alleviate this mass effect that we see developing. So what is the best treatment for a cystic prolactinoma? Because in the literature, cystic nature of prolactinoma is actually one of the qualities that indicates potential dopamine agonist resistance. Often they're lumped with cystic or degenerating lesions, so it's a little bit hard to tell, but they're kind of known to be dopamine agonist resistant. And this group looked at 212 cases that were taken for operative treatment of prolactinomas. It's a lot of data that, just so you know, A, B, and C are just, they looked across different time points to see how these decisions were changing. But they looked at classical indications like dopamine agonist side effects, persistent hyperprolactinemia, and inadequate tumor shrinkage as reasons for prolactinomas to go to surgery. But then they also looked at patient preference, which is what they called modern indications, where patient preference, and then also cystic prolactinomas. And they found that the indication for surgery for cystic prolactinoma, because of being a cystic prolactinoma, increased over time. They found remission rates with surgery were 50% overall, with 91% in micros and 80% in these cystic lesions. So they're showing that, okay, well, you can actually cure hyperprolactinemia in 80% of these cystic lesions with surgery. However, we have data from Dr. Fajay and our own group here at Mass General who looked back to show that dopamine agonists actually can effectively treat cystic prolactinomas. So he identified 30 cases at Mass General. 22 were initially treated with dopamine agonists, and surgery was performed in 15 patients. 7 of these 15 actually, retrospectively, when he looked, never had dopamine agonist treatment. 8 out of 15 did, but still went to surgery either because of medication intolerance, personal preference, inadequate cyst shrinkage, but they did have initial shrinkage, and 3 were determined to not respond radiographically to dopamine agonist treatment. And I think his data is actually quite beautiful. So he actually took these 22 patients that were initially treated with dopamine agonists and plotted them on a waterfall plot to show the change in cyst volume from baseline. This is an increase in cyst volume. This is a decrease. The black color shows that the hyperprolactinemia resolved, and the gray shows that hyperprolactinemia did not resolve. This indicates if they were on cabergoline or bromocriptine, or the star indicates both. And you can see that 20 out of 22 had persistent reduction in cyst volume. The mean cyst reduction was actually 83%, which is quite impressive. And the cyst volume was not predictive of response. And in fact, 2 patients with the largest cysts had excellent response, and the majority of these patients had excellent response. And And interestingly, these two patients who did have reduction in cyst volume did actually not have a resolution of their hyperprolactinemia. So in some ways, there is a little bit of a disconnect here. So the conclusion here is that dopamine agonist treatment in cystic prolactinomas is often successful. So don't skip over that option if present. So she started cabergoline, and we reviewed her mental health history to make sure that she wasn't going to have severe depression, anxiety, impulsivity with the dopamine agonist, advised her on how to take it, and up titrated the cabergoline. So she had a really nice response. So after cabergoline, her prolactin normalized, and after 6 months, you can already see that this large lesion with chiasm impact has really lessened to just this lower left lesion, and the cystic volume started to decrease already. And then at 5 years, it's actually very impressive. She does continue to require cabergoline for hyperprolactinemia, but you can see there's just this hypodensity here. There's actually nothing. This is just CSF space. There's no cystic lesion anymore, and this is her sagittal view. So it's really a great response for this patient, and she was able to avoid surgery, and now she's really more prepared for the future fertility when she wants that. So I'm going to move on to a very brief case, a 50-year-old man with nausea and fatigue. This is an otherwise healthy man, and he ran a marathon 1 month prior, but he now has headaches and fatigue for a few weeks and nausea more recently. He saw his primary care doctor, and besides he had a normal blood count, no anemia, he did have a low sodium, which was surprising, as otherwise his metabolic panel was normal, and he had a low TSH, which prompted a free T4, which is also low. So the PCP was obviously a little concerned at this point, consulted with us, and obtained an MRI as the patient was being ushered to our clinic. And this showed an enlarged heterogeneously hypoenhancing pituitary gland consistent with a macro adenoma. And you can see that nicely. It wasn't thought to invade the cavernous sinus. There was some impact on the stalk, which made it look a little thickened because it was pushed up, but no impact on the chiasm. So he had immediate additional testing where the sodium was confirmed at 128. The urine osms were high, and the urine sodium did not indicate dehydration. So this was diagnosed as SIADH. And because adrenal insufficiency would be a concern in this patient, and because adrenal insufficiency must be ruled out before we truly diagnose SIADH, a quart stim test was performed, which he failed at 13 with the goal of 18. The prolactin was mildly elevated in this patient, but the testosterone was profoundly low with a very low FSH and LH. And so he was immediately started on replacement steroids, prednisone 5 milligrams daily, which might be slightly generous. Many times now we start with prednisone 4 milligrams, but because he was feeling bad and had the low sodium, being a little bit more generous. He had improvement in hyponatremia to 134, although the normal range is technically 135 to 145, so still a little bit low, but did have improvement in his symptoms. He was subsequently started on levothyroxine for central hypothyroidism, and he was scheduled for transsphenoidal surgery for this likely pituitary adenoma. He did have transsphenoidal surgery, and it was the frozen section was suggested of pituitary adenoma. This is just a picture of our intra-op MRI, which sometimes our surgeons use to make sure that they have cleared out as much of the adenoma as they can at the end of the case, and sometimes do go back in. They felt okay this patient felt okay post-operatively, but continued with some fatigue and mild nausea, which we don't necessarily usually see post-operatively. He continued on prednisone and levothyroxine due to pre-surgical deficits. In routine post-operative surgical sodium monitoring on post-op days 1, 4, 7, and 11 were consistent with a mild SIADH picture that just wasn't resolving, 133 to 134, that persisted beyond the post-operative course. And so when we finally got the final pathology, this was found to actually be metastatic carcinoma invading the anterior pituitary. And these were nestled between the anterior pituitary, which was kind of compressed and entrapped by the tumor. The tumor cells were negative for all of our pituitary hormones and neuroendocrine markers, but strongly positive for markers consistent with metastatic adenocarcinoma of the lung. And even when they reviewed the frozen section, they said it really couldn't make the diagnosis until we had those immunostains, even in retrospect. So he was found to have a 2.2 centimeter right lower lobe mass, which is not seen on this, but you can see here the subcarinal nodal mass, which was already thought to be metastatic disease. And so, this really is a good case to think back. On one hand, the MRI appeared consistent with a pituitary adenoma, and pituitary metastases are rare and often present with diabetes insipidus, but the patient didn't have a known malignancy. And also the frozen pathology was consistent with adenoma. On the other hand, the rapidity of his decline and the severity of hypopituitarism was very unusual. And the hyponatremia due to SIDH and his fatigue did not fully resolve with replacement of the adrenal and thyroid axes. And it's very unusual for us to see continuation of SIDH beyond, in advance of the, that doesn't resolve with replacement and that continues after surgical procedures as well. So this is just a quick slide to show that out of 425 cases, breast and lung are by far the most common cause of malignancy that metastasizes to the pituitary. And I think that something to keep in mind is that this group published in Pituitary that over all the years, both of these cohorts, diabetes insipidus is still the most common symptom of presenting a malignancy with a 42% pooled incidence. But there was some suggestion in their series that DI was less common on presentation now, with pituitary deficiencies, visual changes, cranial nerve palsies, and headaches becoming more common with the newer current cohort, which is a little bit smaller than the older cohort. I think one thing to remember here is that, even though diabetes insipidus is the most common presenting symptom of pituitary metastasis, not every metastasis will present with diabetes insipidus. And so it's just something important to keep in mind. I think the way I present this case, it sounds like we were just working up a pituitary adenoma the whole time, when in reality, because of these unusual things along the way, we were suspicious about the case itself, but it still taught us a lot. And I think we were surprised by the frozen pathology suggesting adenoma, but at the same time, somewhat surprised that to find this lung cancer as well. So I want to just summarize that pituitary adenomas are most common, but many pathologies can affect the sella. Cystic prolactinomas are likely to respond to dopamine agonist treatment. Total cortisol can be unreliable in the setting of oral estrogen. It must be considered when you're ruling out adrenal insufficiency in our young women who are on oral contraceptives or oral estrogen. And a pituitary adenoma on MRI and even frozen pathology is not always an adenoma. So I want to say thank you so much. And I hope one day after COVID, you all are able to visit Boston at some point, or visit again if you've been here before.
Thank you so much, Dr. Dichtel. Laura, that was a wonderful talk. I'm going to request our panelists to, if I'm going to ask a couple of questions and make a few comments. Both cases quite fascinating, as they, the cystic prolactinoma particularly. One question that's come in through the chat here is that for the macroadenoma, what would be the duration of dopamine agonist that you would like to try? Because the patient did have some space lesion or space effects there on the optic chiasm.
Yeah, that's a good question. Well, I would say that she had very subtle neurooptho findings, so we weren't as rushed in her. I actually did have a 3-month MRI, but for the sake of time, wanted to show the 6-month MRI. Okay. And so we did watch her very closely, and in consultation with the neuroophthalmologist, it was just a very sort of hint of pallor of that optic nerve. And so we were willing to wait. But in some of the large macroadenomas where we treat them with dopamine agonists, when they present with even fully affected visual fields, we'll reevaluate them very quickly. And if we don't see, within, I would say sometimes days to weeks, depending on the onset, we will proceed to surgery. But some of our patients actually respond quite well. And I do like to emphasize that just because there's visual field defects, it doesn't mean that you can't treat them with cabergoline or bromocriptine, usually cabergoline because it's stronger. I will say that we always consult the neurosurgeons up front, because the other thing you want to watch out for when these very large lesions that you have is the potential for either apoplexy or CSF leaks if you are treating a very large lesion that is causing mass effect with the dopamine agonist. So we kind of like our colleagues to be on board either way. And sometimes I will fully admit that we offer the patient, we can try this medication if you would like to try this, you can go straight to surgery. And we've had patients select different options, but we've definitely had some good cases in both directions. Some patients that were treated successfully and did not proceed to surgery, and then other patients that did require proceeding to surgery because they just weren't responding quickly enough.
Thanks. I'd like a comment from Dr. Tasnim or Dr. Najmul Islam about what we see in terms of in Pakistan in cystic prolactinomas, in your experience.
First of all, I would like to thank her for the excellent lecture that she has delivered on a very, and came up with the two relatively rare cases. Cystic prolactinomas, we don't see that often as everywhere in the world. But initially, we should give a try, and we do give a try, and most of the tumors that cystic prolactinomas do respond in our practice as well. But by and large, we don't see that many cystic prolactinomas in our practice. But again, and one more thing that I wanted to highlight, that the response to one of the questions that was raised by in the chat, that the response to dopamine agonist, maybe it's very quick really in terms of visual improvement. Sometimes not noticed by the patient, and if you do perimetry, that will be obvious there as well. But if you do an MRI, that may not show that quick reduction. So patient perceive the improvement faster than the reduction in the MRI of the tumor.
So thank you, Dr. Laura Dichtel, for that wonderful talk. And those of us who see pituitary can relate to most of what you're talking about. And it isn't so unusual for you to be surprised by what you thought it is and what it actually turns out to be. Two things that I wanted to ask you is about, in the course of treating a large prolactinoma with dopamine agonist, I have rarely come across deterioration of vision as the tumor shrinks. And that is presumably due to the pull on the chiasm. So what is your experience with regards to that? And what does one do with therapy at that point? Do you hold treatment? And the other thing I wanted to ask you was, when you get CSF rhinuria in the same situation, do you go for a surgical plug there and then, or do you wait it out? How do you go about that? Thank you so much.
Yeah, no, thank you. I mean, those are excellent questions. And actually, I can't answer them in an isolated way, because at that point, we're working very closely with our neurosurgeons, actually for both cases. So I will say, as soon as you started saying visual deterioration, I was thinking the chiasm, tethering and pulling that down. And they can do a chiasm sort of procedure where the surgeon in some cases can lift that up. I do think it's prudent to probably stop the active treatment and do the imaging to see if you can see the, what is going on with the chiasm, and consult with our neurosurgery colleagues who are often on board with these cases from the beginning. Because of these, these things come up. And I think that the reality, though, is that the dopamine agonist is quite long acting, as you know. So withdrawal is sort of not immediate withdrawal. And I think the comment was well put. I mean, the response can be very robust, and we often start some of these patients on slightly higher doses than we would start someone in a less urgent setting. And so I think that I would say that that's probably been a more rare circumstance in terms of with the prolactinomas. And having the chiasm tethering. I know that it has been encountered in our group. And I know that, sometimes we do discuss with the surgeons trying to basically tack the chiasm up to prevent that. But that becomes a very difficult issue. And you have to discuss, should what remains be addressed surgically rather than, treating with the dopamine agonist, and involve the radiologist in that as well. And then, the CSF rhinuria, we just immediately get together with our surgeons and defer to their expertise at that point with re-imaging the patient and to look at how the tumor has potentially changed and where they think that leak is coming from. I've had actually a giant prolactinoma with CSF, actually otorrhea, which was also an interesting case. But these patients are just very challenging, and we try and work as best as a team as we can to do the best, make the best decision for them at that time, but it generally becomes surgical.
Thank you, Dr. Laura. I'm Dr. Nanik. I've also asked for you, like, how's your experience about these pituitary stalk lesions? And when the people present with diabetes insipidus and you're suspecting an MRI imaging this kind of infiltrative disorders, and you were not, despite an extensive work, you're not able to find diagnosis. How is about your experience about the pituitary stalk biopsy in these cases?
Yeah, I mean, our group talks about this a lot, and you know, these patients, they go through lumbar punctures, they go through many blood tests, and you know, sometimes, and we actually have a very interested and a sort of research-based immunoneurology group, I should say, and so when we really don't know the diagnosis, we often come down to discussing a biopsy. I actually think that that's, you know, we were just discussing, because the case series that I showed you was basically a decade ago, and I was just discussing with Dr. Swearingen, and maybe we should see if things have changed in this next decade of your cases, and to see what we've been seeing, because I do feel like we're seeing some of these challenging cases that you're mentioning, where we're doing biopsies of these lesions and finding, you know, these interesting diagnoses. But I actually don't know as a whole. I mean, I think there are some cases that are a little bit more confusing than others and less satisfying, but I do think that the biopsy has clarified some in many cases in terms of showing a lymphocytic hypophysitis or, you know, some other distinct diagnosis. So we really do rely on the biopsy in some of these cases when we come down to all of the testing and can't say what it is.
Thank you. Thank you.
We have one
Yes.
question from Dr. Abdullah Shamshad, one of the attendees. He's asking that because of the large cystic prolactinoma, when would you consider, if you would consider, you know, discontinuing dopamine agonist after 18 months, or for such large cystic adenoma, you would not even do a trial?
Yeah, well, in the case of a patient that I presented, I've actually tried to take her off a couple times because she actually does have severe constipation, and I've been trying to help her manage that, because there are other ways to manage that effect. But you know, I think that I think at this point with 5 years, I was able to see that we seemed to get the effect that we were going to get in terms of size, and the cyst part was fully shrunk down, and she has lots of room between the chiasm. And so I think all of these things together, and the fact that she normalized her prolactin, I was actually a little bit hopeful and a little bit disappointed when we did pull off the cabergoline, that her prolactin did pop back up. But I just think it goes to show that when I showed you that MRI, she still does have a solid lesion there that is still robustly producing prolactin, and she still needs the medication for right now. But I don't worry that if I took her off, I feel comfortable giving her that trial, because she no longer has a lesion up at the chiasm that I'm concerned about, and we have a little time. And actually what I haven't seen is that as we've taken her off and on, she hasn't been off for extended sustained periods, but I haven't seen cyst reaccumulation or any jumps in the size of the lesion. And I have tried to watch it closely anytime that she's been off the dopamine agonist.
Thank you. Any of the panelists, if you have any questions before we close this discussion?
So I just want to share my experience of having worked in the public sector, and hence being able to unfortunately see a very large number of fairly advanced prolactinomas, and many of them like fungating tumors, and some of them cystic as well. And many of them, by the time they present to us, have advanced stages of vision compromised. And I do agree with my colleague, Professor Najmul Islam, that just starting them on cabergoline, very quickly, the patient is able to tell you before anything else tells you that the vision is getting a little better. And I've seen many of these very large cystic prolactinomas, you know, melt down pretty adequately over a period of time. But I have not been able to stop their cabergoline at a very, very small dose. They just carry on with it. At this point, I'd like to ask Professor Dr. Dichtel if about the side effect, the vascular side effects of long-term. What is her experience about that?
What our main concern is with high doses of cabergoline, I'm not sure if you were asking about the cardiac effects in terms of the valvulopathy. You know, I think a new study almost comes out every year. In fact, I think one of our journal clubs every year focuses on this topic, whether we're concerned about our patients. I think in reality, there's some studies that show there might be an effect at the doses that we use, but these doses are much, much, much lower than what we see that are used in Parkinson's patients, for example, and that's quite comforting. And also we do try and minimize and take people off over time if we can. I think that in reality, our practice is that if someone is on a larger dose, you know, of cabergoline, we do start echocardiograms, and we will especially do a baseline, because that baseline is very important to, if you anticipate someone's going to be on a higher dose, or it's going to be used for Cushing's at a higher dose. Having that baseline is very helpful, so that in a year, if you get the echocardiogram, you know that, you know, whatever effects were or weren't due to the medication. But so on patients that are on higher doses, I think most of us do cardiac echoes as possible, just for monitoring. But I recognize that the data is conflicting.
Thank you, Dr. Laura Dichtel, for a nice presentation and a great discussion. Now we are moving towards the second speaker, and we have second speaker and Dr. Qamar Masood. Dr. Qamar Masood is Associate Professor of Endocrine in Medicine at Ahsan University Hospital. Dr. Qamar Masood completed his internal medicine residency at Illinois' Nanik Medical Center, Rush University, Chicago. And he did his fellowship in endocrine diabetes and metabolism from Cook Country Hospital, Chicago. His research is focused on diabetes and cardiovascular disease risk reduction. And he is currently running a translation trial on cardiovascular disease risk reduction strategies in South Asian people. And he has over 30 publications to his credit. So over to you, Dr. Qamar Masood. He's going to talk on this pituitary case-based discussion and case-based management of the pituitary disorders.
Dr. Nanik, can you hear me? Thank you very much for your kind introduction. I have my slides here, and I'm going to take the talk further from where Dr. Laura Dichtel has left it, that all pituitary tumors are not pituitary adenomas, even if the MRI suggests that. I think she has discussed the anatomy over there, so we can see a little. For those who have joined late, I will be very briefly going over that. So you can see the pituitary stalk in the middle on this MRI. You can see the pituitary stalk here, and on this sagittal section, you can see the pituitary stalk here, the chiasm here, and okay, and this is another view of optic chiasm. We can see the hypothalamus over there and the cavernous sinus where the lesions can go. Okay, so what are some common sellar and parasellar tumors? So pituitary adenoma is the most common, as shown in the last talk. Then craniopharyngiomas, meningiomas, Rathke, cysts, chiasmatic glioma, dermoid, epidermoid, cysts, germinoma, schwannoma, and metastasis, as the second case told us. Okay, so how can we approach these tumors? First is identify the pituitary gland on the imaging studies and Sellar Turcica, determine the epicenter of the lesion. Is this coming from the sella or is it suprasellar, and is the sella is enlarged or not, or is mostly suprasellar lesion? And analyze the lesion, signal, cystic, solid, phlovoid calcifications, and differential diagnosis. So I will start with a different flavor from the in the first two cases. A 45-year-old housewife presented with a 1-month history of weight loss, nausea, vomiting, and associated with lethargy and palpitations. And for the previous 5 days, the family had observed that she had altered behavior, some sort of delirium and crying spells without any reasons. Okay, the patient had no menses for the previous 16 years since the birth of her last child, which was complicated by the postpartum hemorrhage. She was very thin, lean female with average height, and she appeared anxious. Her blood pressure in the ER was 84/60, and 60 beats per minute was the heart rate. On the day of admission, she became unresponsive and pulseless in the ER. ECG showed at that time that she had torsades, and she was shocked twice and treated with initially with intravenous amiodarone and then switched to lidocaine because of her QTC interval was very much prolonged. A temporary pacemaker was placed for overdrive pacing because of recurrent episodes of torsades. And we can see increased QTC interval. Initial investigation showing hyponatremia. And on the basis of postpartum hemorrhage, secondary amenorrhea, severe hyponatremia, and very low normal blood sugar, diagnosis of panhypopituitarism, causing Addisonian crisis over here, secondary to Sheehan syndrome and myxedema coma-like picture. So if we can see the labs over here for the non-endocrinologist, if you can see that she has very low free T4, but her TSH is normal. So these will be the circumstances where we go by the very low free T4 because TSH fragments are measured as TSH. So they are not really biologically active TSH fragments. And in a very low free T4, this normal TSH is inappropriately normal. The normal range of FT4 ranges from 0.8 to 1.8 nanogram per deciliter. She has again a very low prolactin levels, again suggestive of pituitary apoplexy in the past, Sheehan syndrome. Her cortisol was undetectable, and the echocardiogram showed severe global hypokinesia. She was started on levothyroxine and intravenous hydrocortisone. Her sodium improved, and her heart rate and QTC interval improved. The temporary pacemaker was removed, and she was discharged home on thyroxine and hydrocortisone replacement therapy. This was her MRI, and if you can appreciate that there is an empty Sellar over here, we can see the fluid in the on the T2 in the Sellar. Okay. The second case is a similar case, a 35-year-old housewife admitted with complaints of lethargy, nausea, vomiting for 1 week, and altered behavior of 1 day. The patient had a history of postpartum hemorrhage after her second delivery 10 years ago, and since then she had been amenorrheic. Her blood pressures again was very low, her heart rate was 79, and in the ER she developed monomorphic ventricular tachycardia. This was a picture of that. So she was again given intravenous amiodarone, which led to temporary reversion of her ventricular tachycardia. In the CCU, the patient developed several runs of a non-sustained VTAC, and her ECG showed a QTC interval of 492. She underwent temporary pacemaker placement at that time. Sodium was again very low, 113. You can see she had hypoglycemia as well. So she was in Addisonian crisis as well as likely myxedema coma. Her FT4 again is very low, 0.28. Cortisol not that low, 7.4, but again low for her condition, as she was in shock at that time, and we expect that cortisol should be high here. FSH and LH in the presence of amenorrhea again are inappropriately normal or low, and echocardiogram again show global hypokinesia. I think the global hypokinesia in both of these cases was because of the profound hypothyroidism, central hypothyroidism that these patients were having. She was started on levothyroxine and hydrocortisone therapy, and her sodium improved uh, over next 6 days, and no additional VTAC runs. The temporary pacemaker was removed and the patient was discharged home. Repeat echocardiogram 1 year later revealed normal systolic function for almost 7.5 years. The patient has been following regularly in the clinic, doing well on hormonal replacement therapy with T4 hydrocortisone, conjugated equine estrogen, and progesterone. We published these two cases, long-standing undiagnosed Sheehan syndrome presenting as polymorphic and monomorphic VTAC in these patients. We also reviewed our data regarding hypopituitarism, how hypopituitarism is presenting other than sellar and parasellar tumors or traumatic brain injury, which are the common causes of hypopituitarism. What we find that these patients generally have long duration of illnesses. They more complaints of decreased libido, decreased body hair, amenorrhea, diminished sense of well-being, weight loss, gradual weight loss, anemia, hyponatremia are the common presenting symptoms. Sheehan in this part of the world remains the #1 cause, and then the other portion is empty Sellar syndrome. So many causes is there: mass lesions, radiation, infiltrative lesions can cause hypopituitarism. Infections like tuberculosis, meningitis, traumatic brain injury are the common causes there. So let's switch gears and move to another patient. A 34-year-old male presented to clinic with chief complaints of headache from the last 4 months. He further complained of decreased appetite, weight loss, dry skin, and polyuria, and he had no visual problems at that time. If you can look at his investigations, FT4 is low, and TSH this time is also low. Cortisol is very low. Prolactin is normal. Growth hormone is 0.35. LH is low. Testosterone is undetectable. And we can see that the sodium is high-ish, 145. So serum osmolality is the high normal, 294, and the urine osmolality is reaching close to 600. Perhaps with this, I'm not sure whether these were done with water deprivation or not. This is likely to, looks to me as partial DI in this case. You can see that there is a pituitary adenoma. The chiasma can be seen. It's maybe a little bit abutting the chiasm over there is iso intense on the T1. And this is the contrast. This is showing some enhancement with the gadolinium. Again, a well circumscribed lesion, and you can see the pituitary stalk there. Again, diffusely enhancing. So it measures about 14 into 15 into 11.5 millimeters, and it was reported as suggestive of pituitary macroadenoma. So he was started on hydrocortisone and levothyroxine, and transsphenoidal surgery was done. However, the transsphenoidal surgery, the pathology showed that sections examined exhibiting scattered back-to-back granulomas composed of loose aggregates of epithelioid histiocytes with scattered multinucleate giant cells. No convincing evidence of necrosis there, and these granulomas are surrounded by sparse lymphoplasmacytic infiltrate. Our pathologist was of the opinion that tuberculosis is a likely possibility over here. Clinical and microbiological cultures correlation was recommended. These you can see the pituitary, these are the granulomas, and you can see in between them some islands of the pituitary gland. And in this, you can see a multinucleate giant cell over here, and you can see this is a large granuloma over there. We discussed with our histopathologist, and he thinks that these are more in favor of tuberculosis. Unfortunately, gene expert could not be done on the specimen as it was formalin fixed. He underwent CSF studies, and again, those were non-contributory at that time. If you look at his other laboratory parameters, his ESR has been normal. We worked him for the Wagner's as well. It was negative. The only positive finding was his IGRA was positive. These were the images after these 3 months after the surgery. You can see that the lesion has gone. And again, this is the stalk, might be a little bit thickened. Patient was started on empiric ATT after discussion with our ID specialist, and and MRI was repeated after 3 months and 6 months. So MRI at 3 months, you can see that the Sellar a little bit pituitary here, and you can see the stalk maybe a little bit enhancing. If you can see in this one, the stalk is enhancing, maybe a little bit more prominent, maybe thickened, a little bit thickened. And after completion of the MRI, it may be less conspicuous. So we treated this patient empirically with the ATT, and the patient is doing fine, but he's on hormone replacement therapy. So granulomatous hypophysitis characterized histologically by infiltration by histiocytes and giant cells, sometimes accompanies a known systemic granulomatous conditions such as Wagner's or tuberculosis, reported following treatment of hepatitis C with interferon alpha and ribavirin. So we'll go to the case number 2 very quickly. A 34-year-old married with 2 kids came with the chief complaints of bilateral blurring of vision from last 1 month. It was not associated with headaches. You can look at the free T4 is in the normal range. Cortisol a little bit low, but not profoundly low. Mild elevations of prolactin, and creatinine was normal. If you can look at the scans in sagittal here, this is a lesion which has a enhancing rim, and the center is a little bit dense, as discussed by Dr. Laura Dichtel, that may be proteinaceous material there, or maybe a hemorrhage there. So you can look at the enhancing peripheral rim, which is enhancing. So a hemorrhage would look like this, and a Rathke's cleft cyst look like this, and the patient underwent surgery, and it turned out to be a Rathke's cleft cyst. She developed DI post-op, except that her gonadotropins are inappropriately normal, as she has been amenorrheic with low estradiol. She's otherwise she is doing well. Right. She is on desmopressin as well, so and remained amenorrheic. So persistent amenorrhea, and she was started on hormone replacement treatment. So the clinical characteristics of all kind of cysts are similar. Most cysts are small and discovered incidentally by MRI, and MRI characteristics include a sellar or a suprasellar symmetrical round or ovoid mass that enhances on either T1 or T2 images but does not concentrate gadolinium. Case 5, I think we have still some time for it. 52-year-old male with no known comorbids come with chief complaints of headaches and blurring of vision since 1 month. He had bilateral VP shunt placed due to obstructive hydrocephalus at outside hospital. And if you look at the MRI here, so it's a lesion with multiple small cysts, and the calcification on this MRI would appear black here. Again on the MRI, in the report of the MRI, they could not really comment what is the lesion that they are seeing there. They have described it, but they said they cannot really characterize the lesion. But if you look at the CT scan, CT scan is very much is showing large amounts of calcification, and this large amounts of calcification. So a cystic lesion with calcification is craniopharyngioma, and the surgery showed craniopharyngioma adamantinomatous type. So last case, I think I have some 6 minutes remaining here. A 20-year-old female with worsening of headache for last 3 to 4 months, had off and on headaches for last 3 years, blurring of vision few days before presentation, no fever, loss of consciousness or seizure, primary amenorrhea, but no galactorrhea. On physical examination, she was vitally stable with BMI of 25. Breast development was just 10 or 2. So primary amenorrhea without the development of breast. She had bitemporal hemianopia on visual field examination, and the MRI, she had an MRI earlier as well, which showed a pituitary stalk lesion. But this time when she presented, she refused surgery at that time 3 years ago now, but when she developed visual symptoms, she seek medical attention again. If you can look, FSH and LH are low, estradiol is low, free T4 is very low with inappropriately normal TSH, cortisol is low. So multi-hormonal dysfunction. If you can look at the lesion here on this T1, a large lesion which is extending suprasellar, with the suprasellar extension. Not much in enhancement, or not much on the T2 images. On the sagittal, you can see a large lesion here, and she underwent actually biopsy, and multiple fragments of lymphoid tissue predominantly exhibiting varial sized lymphoid follicles, immunohistochemical stain, and CD117 highlight individually scattered germinomatous cells. So this was a germinoma. She was given chemotherapy, including carboplatin and etoposide, followed by radiotherapy boost. The size of the tumor was much reduced, and this could represent a scar tissue. She required thyroid and cortisol replacement along with desmopressin. So a few words about intracranial germ cell tumors arise almost exclusively from midline locations. In a young girl with midline lesion, one could think of germ cell tumors. The two most frequent sites are pineal gland and the suprasellar regions. Pineal GCTs present as neuro-ophthalmologic abnormalities, especially paralysis of the upward gaze and convergence. Endocrinopathies are rare. Suprasellar GCTs most commonly present with hypothalamic pituitary dysfunction, including DI, delayed pubertal development, or precocious puberty, isolated growth hormone deficiency, or other aspects of hypopituitarism. Suprasellar GCT can also cause ophthalmologic abnormalities, as in our case. On MRI, intracranial GCTs appear isotense on T1, or isointense or hypointense on T1, and hyperintense on T2 sequences. These tumors typically show homogeneous enhancement with gadolinium, or heterogeneous enhancement if cysts are present. So my final slide here, benign tumors, causes of the Sellar masses. It may be benign tumors, pituitary adenoma, most common Sellar mass, then craniopharyngioma, meningiomas, pituitary hyperplasia like lactotrope hyperplasia during pregnancy and thyrotrope hyperplasia um, during hypothyroidism, somatotroph hyperplasia due to ectopic growth hormone releasing hormone. Malignant tumors, primary, maybe like germ cell tumors, sarcoma, chordoma, pituitary carcinoma is rare, metastatic from lungs and breast. Cysts like Rathke's, arachnoid, dermoid, pituitary abscesses, again very rare, and lymphocytic hypophysitis or carotid AV fistulas can also present as Sellar masses. So thank you very much for your attention.
Thank you so much, Dr. Qamar Masood, for a wonderful presentation and excellent cases you presented with regard to the Sheehan syndrome, who presented with the cardiovascular complication like cardiac arrest and ventricular tachycardias. And we have the question from the audience that what is the exactly mechanism of like cardiomyopathy in these two cases of Sheehan syndrome, which presented with the cardiac arrest, and with the improvement with the hormone replacement therapy.
I think as this is profound profound and long-standing hypothyroidism. So thyroid hormone, as we can see even in the subclinical thyroid disease, we can sometimes able to appreciate some abnormalities in the myocardium. So long-standing and profound hypothyroidism is the main cause of cardiomyopathy over there. There is some role when we look at the search, when we were publishing this, we looked at there was some role of cortisol as well, but I think thyroid hormone, deficiency of thyroid hormone is the main reason for which improve with replacement in this case.
Okay. We have also another question from the audience. This is like a lot of the patient, like our audience want to ask a question about a lot of the patient coming with history of the headache on and off without any symptoms. You want to ask the when to go for the brain imaging. Just a simple headache.
So a difficult question, I would say, in our setting because of the cost and other things. So if the headache is daily headaches, everyday headaches, if the visual symptoms are there, or if there are any hormonal deficiencies, those were the cases there where we go for imaging of the cell. If the patient is amenorrheic or galactoria is there, headache is there, visual disturbance is there. Often, I mean, if the regular headache is a feature, I would go for imaging.
Thank you. And Dr. Qamar Masood, how about this pituitary tuberculosis case? Till how long you like given ATT to this patient? Like because it's an extrapulmonary tuberculosis, and so recommendation the prolonged treatment is needed. So till how long you treated this patient with ATT?
We gave him ATT for 6 months. The current guidelines for TB in WHO guideline, I've discussed that with the pulmonologist and the ID physicians too. The guideline says 6 months for TB anywhere. Currently, the current guidelines.
Right. So let's go to our experts and any thoughts about this? These cases Dr. Qamar Masood presented.
I wanted to, I mean, the Qamar presented a series of good cases really related to the pituitary gland. I noticed that in his second case of Sheehan syndrome, in the hormonal workup, though the patient had hypoadrenalism, the potassium was low along with low sodium. So that was slightly odd because I was expecting, and everybody would be expecting a raised potassium rather than a low potassium. So I just wanted to ask Qamar, was there any other reason for this hypokalemia in this patient?
Now in central hypoadrenalism, central deficiency, I mean, there is no deficiency of mineralocorticoids. So potassium is either generally normal in these cases. Since it has been more than like 9 or 10 years, I exactly don't remember whether she was having vomitings or other thing. Is there any other reason for that? So I can't be sure was there any something else going on causing hypokalemia at that time. She might be having vomitings or other things.
Because I have presented a series of patients with central hypoandrogenism presenting at hyponatremia, and in all those patients, the potassiums were well within the normal range, but in none of them it was
Yeah.
low. So that was
Yeah.
slightly.
So low is not expected,
Hmm.
neither high.
Okay, and one more thing that I just wanted, if you have any experience with pituitary abscess, because I treated a patient with in which we were suspecting cystic pituitary adenoma, but during surgery it was an abscess that was drained and it was sent for culture. Nothing grew, and then we had to treat with antibacterial in consultation with the IID specialist for a period of about 4 weeks. So, do you have any experience with uh, pituitary abscess?
No, a real pituitary abscess I have not seen case yet. Uh, Many times when the surgeon aspirate these lesions, cystic lesions, they are concerned that we perhaps have, as like in the patient with the craniopharyngioma and as well as in the Rathke's clefts, both of the times the surgeon suspected that it could be an infection there or abscess there, and they have sent for microbiology and other tests in these cases, and were in both cases it was negative. So surgeons sometimes, when they operate on these cases, they thought they are dealing with the infection, but
So, but
but really, yeah. But I have not seen a case yet.
because I mean, in the histopathology portion of the tissue that was sent, it wasn't Rathke's or a craniopharyngioma in that case. So it was purely an abscess, but nothing grew from it. Anyway, so I mean, I think the good series of cases that you have presented, and it's really some of them have been very rare, particularly the ones, the two Sheehan syndrome, in which severe compromised heart function was there with Torsades de Pointes as causing ventricular tachycardias. That was, I haven't seen that in my practice.
Professor Tasnim Ahsan, what's your viewpoint?
Thank you, Dr. Qamar Masood, for that very interesting array of pituitary cases. Just tells us that, you know, when you think pituitary, you think adenomas. And then when you see cystic lesions, there are quite a list of possibilities. So the thing to do is to keep your mind open, and really the way you clinch these diagnoses, I mean, some of them can be suspected on the kind of MRI picture that it presents. But as Dr. Dichtel showed, even in the best of places, what you think is, you know, a cyst or Rathke's cyst turns out to be something else. So the clue here is to just keep your mind open about the possibilities, and everything that looks solid is not a pituitary adenoma, and you end up being surprised. And here is evidence of it for the cases that Dr. Qamar Masood just presented. As for Sheehan's, we used to see a lot of them in the public sector, obviously. The deliveries, the patients, the class of patients that attends them are people who also have bad obstetric care, and, you know, postpartum hemorrhage is therefore in order. And some of these electrolyte abnormalities, like Dr. Qamar Masood showed, are really perplexing, and they are contributing to the potassium relationship that you expect in an uncomplicated Sheehan's. So there you are. Thank you very much. Very interesting cases. Thank you.
Thank you, both Dr. Najam, Dr. Tasnim, Dr. Nanik, Dr. Sara.
Thank you so much, Dr. Qamar Masood. And now I'm handing over to Dr. Sara Nadeem. We also a guest speaker, and Professor Gary Hammer. Over to you, Dr. Sara Nadeem.
Thank you, Dr. Nanik. Thank you, everyone, for participating for the pituitary session. And now it's my pleasure and honor to introduce Dr. Gary Hammer, the current president of the Endocrine Society, for his address, and to be introduced to the Pakistani endocrine community, which is signed in today for the PES 2020 event today. Dr. Gary Hammer is current president of the Endocrine Society and is also a practicing endocrinologist and researcher at the University of Michigan. Over to you, Dr. Hammer. Thank you for joining us today.
Thank you so much, Sarah. Gary Hammer here. Nice to see you all. Let me share my screen for you. Give me a second. Can you see that? Great. Well, hello everybody. Like I was just introduced, Gary Hammer. I'm the current president of the Endocrine Society, and I'm really pleased to be invited to virtually to your 2020 Pakistan Endocrine Society annual meeting. So thank you. I mean, I really want to thank all of you and your leadership for the invitation to engage with all of you during your PES annual meeting. As you probably know, the Endocrine Society's mission is to unite, to lead, to grow, and to really grow the global endocrine community. So we're extremely proud to partner with the Pakistan Endocrine Society. It goes without saying that it's collaborations like this one that are important to the global endocrine community. And though I would have liked to have been there actually in person and visit your wonderful country, we commend all of you for delivering this meeting's educational content virtually during these extraordinarily challenging times. We're all learning that the ability to stay connected is more important than ever as colleagues and with our patients. And so I'm honored to be here to share with you, to share this virtual stage with you all. So let me just give you a snapshot of the Endocrine Society. What I show you here is just some data. We're a global organization representing endocrinologists and endocrine scientists around the world. We have 18,000 members with countries representing 120 countries represented around the world, including, as you'll see on the next slide, so these members are researchers, clinicians, et cetera, industry members, educators, including many Nobel laureates among our leadership and members over the years. And you'll see here that we've basically increased our numbers remarkably over the years. The numbers in purple are countries where we do not have members, but the rest of the world is very well represented, including members from Pakistan, as you well know. So recently we retooled, we re-envisioned our strategy moving forward for the next 5 or 10 years. And this really serves as our roadmap. And you'll see here some of the principles or priorities that I'll be discussing and have discussed a little bit over the next 10 minutes that really focus most importantly on global leadership and global engagement, not just in the virtual world that we find ourselves in, but just moving forward for the field of endocrinology and to unite all of us so we have a greater voice, greater impact, and greater influence. And both of our societies, the Pakistan Endocrine Society and the Endocrine Society, are deeply committed to developing a pipeline, our future leaders, our trainees, who will be the voice of the future. Each year, you may not know this, but we offer a global leadership academy at, well, when it's live, at the Endocrine Society annual meeting. And think about this for the future of your members. This platform provides leadership and professional development skills for the up and coming scientists and clinicians to help accelerate their careers and to help give them the leadership skills to guide us all into the future. So what are our main meetings? Of course, as you probably know, are what we call Endo 2021, which is coming up, and our CEU, which stands for our clinical endocrine update. And we collaborate, in addition to that, with many international societies throughout the year to co-host meetings and sessions in many countries. Some examples over the years, I mean, of course, different societies around the world may use members of the Endocrine Society to give seminars and talks, but we also have deep collaborations to develop meetings, as we've done this year in India, Saudi Arabia, Peru, Argentina, Brazil, and Turkey. So those are things to think about in the years to come. I mean, this year was hard. This year we had many challenges where we had to really lean on our professional community, as you did, for strength, encouragement, and guidance through the COVID epidemic. And I must say that despite our inability, like your meeting here, despite our inability to gather, socialize, and learn in person, I'm immeasurably proud of our global endocrine community that I think, because of the epidemic, is, believe it or not, more connected, more united, and more inclusive than we were before COVID. And it's really our diverse community that has embraced digital learning as one alternative form of connecting. And in doing so, we haven't totally obviated traditional barriers like time and distance, but we've done a pretty good job in the virtual space. And it's really propelled us forward, as you'll see. We recently launched an online member community called Community Connect that I urge you to look into, where endocrinologists around the world interact with their peers during the pandemic. And we invite you all and your members to share, connect, and participate in this network. Our Endo Online 2020, we launched this in June. It was our inaugural online conference. This was challenging because we had to pivot from a live meeting to a virtual meeting within a few weeks. And I must say, we attracted over 27,000 participants, 27,000. The largest event in endocrine history. Over 90 countries, I think, participated with live and on-demand programming. This included 2 sessions on telemedicine and in the age of COVID, and the impact of COVID on endocrine care. And I believe that content is still now available to all Endocrine Society members through our online educational portal. It's worth looking at those. They're very educational. Our clinical update also was delivered virtually this year. And CEU, I think, is recognized not only for its comprehensive in-depth programming, but also for the opportunity for practicing endocrinologists to learn and collaborate with peers from around the world. It's 28 hours of content, up-to-date clinical content with more than 12 sessions where participants could connect in real time with leading experts in very difficult cases. And these are still available. It won't be live anymore, but they're still available for viewing and education. All right. I'm sad to say, but my sadness is being buffered up, but I'm sad to say that we just recently made a decision that our Endo 2021 must be online. It is still too difficult to travel, but we again have had much more time to prepare. We have time to prepare for this March meeting, and we hope that you'll join in this exciting program. It's going to be a full program that we hope to really mirror the live program with top flight educational program, an interactive expo, and networking possibilities. So registration is still open till November 18th. Okay, our journals are still remain strong. Fast and efficient peer review, as you probably know. A wide array of new author benefits. We're available now in 55 countries with 102% increase in subscriptions and circulations. So JES is the new open access journal that I hope you also can have access to. You should. The JES, Journal of the Endocrine Society. So that's all I want to say about that. And our endocrine news is really up-to-date monthly news about endocrine science and care and advocacy around the world. Okay. I know this is long, but I had to give you a full flavor of what we have to offer. Our clinical practice guidelines. These are some of our most attractive and read copy. You can get them on the web. You can get them in paper, and you can get them on cell phones. So if you haven't downloaded our guideline mobile app, it's really helpful and easy to navigate on a phone. So and of course, we offer educational opportunities for those taking their board exams. These are, while they are geared towards the American boards, they're quite applicable to endocrinology around the world, along with our Meet the Professor sessions that folks attend. We are evolving an ever-increasing outward-looking focus of our team to help patients. Of course, a lot of our online presence is facing towards clinicians and practitioners. We're developing more and more content to share with the world as patients become more and more empowered, more and more engaged in their own care around the world. And with access to the internet, we need, all of us in endocrinology and all of our societies need to provide real content with scientifically based data. And we're doing a much better job at that over the last couple of years. Almost done. Because endocrinology is a vast discipline with many of us involved in various aspects of endocrine care, some generally, some in specific areas like the adrenal or like the pituitary, like your fascinating last session. So we offer now special interest groups for our colleagues, where colleagues gather. Right now it's virtual, but it's also live when we have our endocrine meeting, to talk through issues and to meet people with similar career interests. We think this allows really worldwide colleagues to interact in smaller networks of engagement. The idea is to foster connection. Okay. And so there's the website, Community Connect. We urge you to take a look. And then lastly, we have worked really hard to do our best to provide service, knowledge for endocrinologists and patients, but for endocrinologists particularly during COVID. In America, we've been on Capitol Hill advocating with our legislature. We have worked on expanding coverage for telehealth and public health awareness. While I can argue that has most value in the US because it's about our telemedicine rules, we're learning a lot, as you are, about telemedicine and practicing care over the internet, and that's very helpful. And we held a bunch of telehealth webinars associated with our annual meeting, which were very helpful. And if you have COVID-related articles, they're now being fast-tracked for acceptance. Well, they have to be peer-reviewed still, but they're being fast-tracked for review in our endocrine journals. And like our other communities, we have a COVID member community that has lots of resources in it for your support, for your help, that you can find on our website, that really is added to every day as information comes out from leading health organizations around the world that's pertinent particularly to endocrinology. This is very valuable for endocrine care during COVID in real time. So I guess I'll say this in closing, and I'm sorry that I was long-winded, but while nothing has been close to usual in the last 12 months, we will continue to be as nimble as we can and adapt to our needs of our members around the world, including all of you in Pakistan, to help our members, our patients, and the world as we move forward. I truly believe that through our courage and our joint courage as an endocrine community around the world, through our courage and resilience, we will get through this difficult time and we will come out stronger, clinically and as a community. So maybe I'll close there and say I really want to thank the Pakistan Endocrine Society for providing me this opportunity to stay connected with you and our colleagues during this challenging time by hosting this virtual meeting. So thank you again to all the organizers for allowing me to participate, and I look forward to seeing you all again in person sometime soon. Thank you very much.
Thank you so much, Dr. Hammer. We're grateful for your talk, and like you said, there's no better time, and in our lifetimes, I think it has shown us that how collaboration is key and connection is the way it is. And like you said, people have stepped up and are more connected virtually than they've been before. And we look forward to, we have hundreds of Pakistan Endocrine Society executive members. So we really hope to increase the number of membership numbers. They're definitely more than 30 from Pakistan that can really play a role.
I know that. I know you have a very robust endocrine community. And I'll tell you, for like some of you on the call here right now, working in rare endocrine diseases, collaboration is absolutely essential when it comes to simply difficult case management, the development of best practices, let alone the research efforts. So absolutely, I look forward to more continued and deep engagement with the Pakistan Endocrine Society.
Wonderful. And I'll introduce you to our panel. That is there, Dr. Tasnim and Dr. Najmul Islam, both professors of endocrinology and both instrumental in actually launching endocrine as a training program fellowship in Pakistan in 2002, I believe that was. And Dr. Nanik Ram is one of our, is the first FCPS. Dr. Nanik, why don't you go ahead and introduce yourself? He is the first endocrine fellow that graduated from FCPS, right?
Yes. Yes.
So we've got lots of trailblazers here.
The world needs more trailblazers like you both. And I think endocrinology needs continued trailblazers. So I really commend you and thank you for the whole world of endocrinology for your efforts. I can appreciate a little bit how challenging that must be in this day and age with our polarized world.
Thank you so much. If there's any comment from Dr. Tasnim or Dr. Najam before we end, we'll unmute you.
Okay, first of all, I would like to thank Dr. Qamar first for his introduction to the Endocrine Society. I mean, I'm a member of the Endocrine Society of US as well. And I benefit from all your educational material that the society provides really to the members. And I think we would like to be very happy to collaborate with you, and we would like to attend your annual endo conferences really, particularly when it comes to physical meetings. But obviously virtual also is very important for us, and we continue to benefit from the experience of the experts in US. Thank you, Gary, for your presence here in this session of Pakistan Endocrine Society.
Thank you. We will both do our best to make that interchange and exchange valuable moving forward.
I look forward.
Thank you, Professor Hammer, for that introduction to your endocrine society starting in 1917. As compared to you, we are really little children yet, because I remember some 20 odd years ago, we established our society, and both Professor Najmul Islam and myself are founder members. And I'm the only woman who's the founder member there. And now I'm joyous to see that our endocrine community is growing by leaps and bounds, and it's more and more women. So we look forward to interacting with your society in future and learning from you and sharing our experiences with you as well. Thank you.
Overwhelming courage, passion, dedication on your part. Really remarkable efforts. And yes, we will continue to engage as we work hard to enhance health equities, inclusion, and diversity, not just in the Endocrine Society in the US, but around the world. So you are front and center in that mandate to all of us. Thank you so much for all you do.
Thank you, Professor Gary. And being now, I'm also a member of the Endocrine Society, and recently I got a permission from Hormone Health Foundation for translating these pamphlets and patients' care pamphlets, and been translated in Urdu and get posted on this Pakistan Endocrine Society website. And I'll also be contacted by your team, Hormone Health Foundation, to translate these COVID-19 in diabetes, the patient patient care pamphlet, and then I submitted to your team, the Hormone Health Foundation, about the COVID-19 and diabetes.
That is fantastic. I tried once to get a textbook, an old textbook translated from simple German to the US and to English, and it was very, very difficult. Never did it. So what you're doing, I understand the challenge of what you're trying to do.
Yeah, it's very challenging to translate that in Urdu. Urdu is like, it's again a very difficult language, So it was very hard to translate it in an Urdu, and then we get to be posted on the website on your own.
Where did you get funding for that?
Well, it's not funded. I did myself, because your team from Hormone Health Foundation, and they just asked me to, because at that time in the pandemic time, they get me to translate this in Urdu, the COVID-19 and diabetes, and they provided me the English version, and then I with help of the professional colleagues, and then I translated that in Urdu.
Well, you are to be given some huge award, something. You're doing amazing effort, and you're to be commended. Thank you so much.
And also, with the help of the professional people, and the patient pamphlets also been translated in Urdu, and they are on the website of on Pakistan Endocrine Society. I took a special permission from Hormone Health Foundation.
Well, if you need anything, email me or call me, and I can. The Endocrine Society, it's not that large in terms of staff, and hopefully they're responsive to you. But if any of you ever need anything that the Endocrine Society can help with, just reach out to me, even if I'm no longer president.
Thank you so much. Thank you so much.
I'll do everything I can to help, because I'm so delighted to meet you all and the amazing things you've all done.
Thanks so much.
Thank you again. And I'll close the session now. Thank you so much for your time. Thank you. Thank you, panel. Thank you, Dr. Nanik, Dr. Najm, and Dr. Tasnim Ahsan. Thank you, team. Thank you for everybody participating.
Thanks so much.
Bye-bye.
Bye.
Nafis.